And RCTs, I take it, as you know from yesterday, are randomized controlled trials, not rational choice theory, which I also talk about because at LSE I'm embedded in a internationally distinguished choice theory group. I wanted to start by telling you about two stories. One is about the Bangladesh Integrated Nutrition Project that was taken up on the model of a similar project that had been successful in Tamil Nadu. The idea of the integrated, well, first of all, there's widespread child malnutrition in Bangladesh, and in particular in the villages where the project was tried out, as there had been in Tamil Nadu. And the idea of the integrated nutrition program is that even given scarce resources, many of the children in these regions could be better nourished if they were nourished differently from the resources available, so that there are, so it is said at least, some mistakes that people are making in feeding their children. One is, I think, a perfectly reasonable desire of mothers to feed down during pregnancy because it's supposed to make delivery easier, but it's not good, not so good for the newborn child or the unborn child. So there was this program to educate mothers about better ways to serve their infants and preborns' nutrition needs. And it went along with a supplemental feeding program that is providing supplemental food for the families where even the resources available didn't reach to the level that would provide enough nourishment for the children. And this project was tried out in Tamil Nadu. Tamil Nadu had at the same time a number of other projects to improve childhood nutrition. Childhood nutrition did improve dramatically in Tamil Nadu, and very good post-hoc studies, not RCTs, but post-hoc evaluation studies carefully carried out, attributed a large part of the success to the integrated nutrition program. The integrated nutrition program was then adopted in Bangladesh on much the same model, and it didn't work at all, and even after 6 years, the nutrition levels for the young children were not any better than they had been before. Okay. That's story number one. Story number two is one about bicycle helmet laws. So if you do case control studies and just intuition, things you know about heads and bicycles and accidents, you'd expect that bicyclists wearing helmets would reduce head injuries. Okay. But in places, some sample places where helmet laws were introduced, there were time series studies, again, that wasn't introduced by a randomized controlled trial in which you made half the bicyclists wear helmets and forbade the other half to, which would be ethically unreasonable. Forbidden, happily, in most places. They were time series studies, though, of places where bicycle helmet laws were introduced. And as you see, jurisdictions that have implemented helmet laws have no noticeable change in rates of head injuries. In fact, in some of them, the rate of head injuries went up rather than down. So those are the two stories I want you to keep in mind. Okay. Now, in thinking about whether a project has worked or not, the gold standard for evaluation is supposed to be the randomized controlled trial. So if you're implementing a new policy in much of the world, you will be urged to implement the policy in a way that allows it to be evaluated by a randomized controlled trial. And there are, of course, ethical considerations and practical considerations that will stop that, but worldwide, Western worldwide, there's this big drive to evaluate projects and to make sure they're evaluated by randomized controlled trials, which are taken by many to be the only way to be sure about causal conclusions. And what you want in your, to know about your policy is that if there was an improvement, the policy caused it, not just that things improved over time. So are RCTs the gold standard? And if they are gold standard evidence, what kinds of claims exactly are they evidence for? Okay. So what I want to address today is what does it take to make a good, a positive result in a very good RCT, for instance, on the integrated nutrition program in Tamil Nadu. What does it take to make the results from the Tamil Nadu study relevant evidence for what will happen in Bangladesh? Okay. Or what will, if you've done a study of bike helmets, one of those case control studies that we had in the original cases of on bicycle helmets, what does it take to make those studies relevant to predicting about what happens if you introduce bike helmet laws here? Okay, that's the question. And not surprisingly, having spent yesterday defending a theory of evidence, an argument theory of evidence, I'm going to look to the argument theory of evidence to provide for us an answer. What does it take to make these studies evidence for the success of the policy if we roll it out here? Okay. Now, let's think about causal principles for the study population. Okay. So I begin by assuming that causes do not produce their effects by accident or by hap, that at least in any areas of the kind we're really hoping for here, where results are in any way predictable, causes will produce their effects in accord with causal principles. And so suppose that the y is going to be our outcome variable. Suppose that y outcomes in the study population are indeed determined by a causal principle, and I'm going to use this simple linear form. It really is as general as one needs, but nothing I say and the simple result I'm going to show you, it holds for more complex functional forms as well. But let's do the simple one because it's easy for you to see what's going on. So suppose that y is produced by a causal principle like this. The C equals, right, means that the quantities on both sides of the equation are always equal, or always equal in the study population, and moreover that the ones on the right-hand side are causes of those on the left. And next meeting I'm going to talk a lot about what it is for something to be a causal principle. But let's just go with our intuitions at the moment. Okay. So suppose this, that the outcomes in the study population are determined by a causal principle, and that there's a probability measure over these variables, alpha, beta, x, and w. X is going to be our policy variable. Okay. So start with those suppositions, which are the standard suppositions, because they all use all these guys use probabilities. They talk about effect sizes, which are mean values. Mean values presuppose probabilities. So these are two assumptions that are built into the methodology. And the methodology, I mean, you don't even have doesn't make sense to be doing RCTs if these principles don't hold. Okay. Now, the standard outcome that's measured in a randomized control trial is the treatment effect, or sometimes it's called the average treatment effect, and I always forget whether I've decided to put the average into the definition of it or not. Okay, so the treatment effect here, see, I have defined it as an average. Expectation is an average or mean. It's the expectation of the outcome in the treatment group minus the expectation in the control groups. You know, so in a randomized control trial, two groups, right? The treatment group gets the policy, and the control group doesn't get the policy. It either gets business as usual, or a placebo, or an alternative policy, and it will make a difference, of course, what you're testing against. But that's not the issue for the moment. So. We'll assume that the treatment, the value of the policy in the treatment group is little x, and the value of the policy in the control group is x prime, and this is just the definition. You look at the difference between the means in the two populations, hoping, right, for a successful policy that the mean is bigger in the treatment group than in the control group. Okay. So as I say, that it's just the difference between the average in the study group and the control group. So what? I mean, so this is, we define this quantity, right? What interest is it? Okay. Well, here's what you're supposed to have done in a randomized controlled trials. You're supposed to have randomly assigned, to have a large study population, and the study population is assigned randomly to either the treatment or the control group. The random assignment of individuals to treatment and control group is supposed to assure, it doesn't assure, but it's supposed to, it aims to assure, and if it's a large enough, very, very large population size, it makes probable that all the other relevant causal factors are distributed the same in the treatment group and in the control group. The random assignment makes sure that whether you get the treatment or not is probabilistically independent of any of the other causes, and the other causes here are alpha, beta, and W from our causal principle. So if, I suppose I should have put the, yes, here's our causal principle, and if X is probabilistically independent of alpha, beta, and W, it turns out a little arithmetic will show you that the treatment effect is just equal to the average of the betas times the difference between the treatment and the control. And if you want to do it really simply and call the treatment 1 and the control 0, then the average treatment effect just is the average of those betas. Okay? That's what it is, okay, mathematically. So if the average treatment effect, you measure it, you have to take the average in one group versus the other. Of course, you have, actually, it's more complicated than that. You don't just look at the actual averages on the finite frequencies. You usually have to do a lot of statistical correction, and then you measure how likely you are to have actually gotten the real averages rather than from the finite frequencies. But anyway, all of that, let's imagine you actually have got the real average. If it's bigger than 0, then obviously X is a cause. If this is bigger than 0, then obviously X has to appear in this equation, and moreover, beta has to be bigger than 0 for at least some of the individual units in the study. Okay, the individual units might be people, they might be villages. In the case of the Bangladesh and Tamil Nadu Integrated Nutrition Program, they were families. They were children. Okay, so if the treatment effect is bigger than 0, then you can see that shows you something about the causal principle. It shows you that the policy really is a cause and a causal principle, and moreover that at least for some units the betas were non-zero. Okay, so positive RCT results show. I use a language, this is just to make it sort of simple, that the policy can play a causal role in producing the outcome under the causal laws for the study population S. So the study population, we'll call it S. We talked about the causal principle that governs the production of the outcome in the study population, and what we've learned about is something about that causal principle. And it can play a causal role. That means that it's actually there in the principle. That's all I mean by can play a causal role. And then what we've also learned is that the requisite support factors for it to play a positive role obtained for some u's in S. Now, I'm going to call those betas support factors. I'm going to explain why I call them support factors in a minute, but the betas are support factors. Okay. So all I mean by X can play a positive causal role in producing Y is that, as I said, it's genuinely there in the causal principle. Now, looking forward to discussion for tomorrow and Friday, if X can play the same causal role widely, I say it has a stable capacity. I'm not going to talk about that very much today, but it's actually the other way around. This isn't a definition of a stable capacity, but if something has a stable capacity, it can play the same causal role across a wide variety of causal laws. Okay. So, now, that's what happens in the study population. And what we've learned from a positive RCT results in the study population is something about the causal principle that obtains there. Okay? Now, what about the target? Okay. the policy won't work in the target unless the study and the target laws share the causal role. So we've learned something about the causal role of the policy in the study population. That's totally irrelevant to the target population unless the target and the study share the same causal role. Okay? And then the other thing is that when you're in the target situation, some of the units in that target must have all the supporting factors necessary in the target situation for the policy to play a positive role there. Remember, what we learned was that X was actually in the equation for the study population, and that some of the betas were non-zero. Okay. Now, that's totally irrelevant unless they share the causal role of X, and moreover, over here, some betas are non-zero. It's a little more complicated, I'll explain in a minute, but this is the support team that has to be there in order for X to play its role in the target situation. So let me now explain why I call these betas support factors. Probably many of you already recognize that, but let me talk a little bit about support factors and causal cakes. And just use an example, homework. This is from a study by a colleague in North Carolina, colleague Harris Cooper. Homework, assigning homework can produce higher test scores, and it regularly does so in studies. So we have to refine both the cause and the effect more carefully if we're talking properly. How much homework, what kind of homework, when, where, under what circumstances, and what kind of test scores we're interested in. But for the nonce, just let's summarize it. But homework can produce higher test scores, and it does so in some RCTs. So, but it doesn't do so without support, and that's what Cooper's work is there to tell us about. So he tells us that homework, for instance, can produce higher test scores, but only if we also have motivated students with a reasonable amount of ability, study space, supportive family, consistent lessons, work feedback, and some other stuff that he hasn't quite figured out. Okay. These are called causal cakes. Actually, epidemiologists call them pies. Okay. I don't like to call them pies because if you have a pie and you take out one piece, you might think you've got a pie left, or you've got quite a lot of pie left. But the whole point about support factors is that if you take out a piece, you don't get the result at all. Now, I mean, of course, you might well, if you take out one of these pieces, get some improvement in test scores. So it really depends on what level of test score you're aiming for. But to get the predicted, expected level of test scores, Harris Cooper says you need not just homework, but you need some support factors. If I had longer, I'd show you that there are also other causal cakes that include homework and don't have some of these, but they have something else. Okay, so there are a variety of different causal cakes that improve homework, but there's no causal cake that will give the improvement in test scores that has homework in it that doesn't have any of these helping factors. Okay? Now, as I say, I call them causal cakes rather than causal pies because I think of pancakes. And pancakes need, at least American pancakes, they need a rising ingredient, they need flour, they need milk, and they need eggs. And if you take away any of those ingredients, you don't get pancakes at all. Okay? So I call these causal cakes rather than following the epidemiologists who call them causal pies. Okay? So the point is that the other ingredients are necessary to ensure that the homework is properly effective. Now, this talk about, so the betas in the, sorry, I should have gone back then to the, I'm not very good at putting the, remembering. Here's our causal principle. Okay? The support factors then are what are named by the betas. If these don't have the right values, then X just simply doesn't contribute anything. Okay, so essentially, think of that as not having the support factors is beta, the betas are zero. So what beta represents in one fell swoop is all of the support factors, all of those other ingredients in a causal cake. Okay, so I want to show you somebody else who worries about totally independent, separate language. Somebody else who worries about these support factors. Ed Lemur, he's famous for writing a paper a long time ago called Taking the Con Out of Econometrics. And recently, in a discussion of the use of RCTs in economics, they are all the rage now in development economics, which I'll talk about tomorrow and Friday. Lemur wrote a paper called Taking the Con Out of Economics. Okay? And here's what he said. I love this because it was exactly on the same point I've been trying to make about support factors. He said, the overall treatment effect, that's our beta, is not a number but a variable. Often if you look at these equations, I mean, I was careful to put a u after the beta, so it gave you the idea that it might vary across the units, but usually the u's are left out, and people think of the betas as being fixed parameters and not as being variables that name real things like student motivation. Okay? So the overall treatment effect is not a number but a variable that depends on the confounding factors. Confounding factors for him then are things like student motivation. If little thought has gone into identifying these possible confounders, it seems probable that little thought will be given to the limited applicability of the results in other settings. Studying the average treatment effect, Lemur claims, is a little like the lawyer who explained that when he was young, he lost many cases he should have won. But as he grew older, he won many that he should have lost. So on average, justice was done. Now, philosophers, I hope you're all familiar that all I've been stressing is something we learned from J.L. Mackie a long time ago, is that causes are Inus conditions. They're Inus conditions for contributions to their effects, but I want to run through that so you make the connection that this is all very, very familiar. It's interesting, it's very familiar to us, but it's something which is just not really noted much in the evidence-based policy literature, which is why Lemur has to write it in a paper called Take the Con Out of Economics. So an Inus condition is an insufficient but necessary part of an unnecessary but sufficient condition. Okay? Now, notice that I say causes are Inus conditions for contributions to their effect. I'm going to talk about contributions again tomorrow, but roughly, sort of contribution is, if you think about Mackie, right, Mackie talked about two valued variables. Causes and effects. The causes are either there or they're not. The effects are either there or they're not. And then he wrote equations formulae like this. E occurs if and only if A1 and C1, or A2 and C2, or blah, 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 where C1 is the salient factor, the thing we call the cause. And A1 are all those auxiliaries that are necessary for the salient factor to work. That just means the A's are the helping or support factors that in the equation got represented by betas. So maybe I should have used B's here to be more reminiscent, sorry. And what you have here is that each of these is sufficient for E to occur. Okay? None is necessary because there's always more than, what they say, more than one way to skin a cat. If you don't have this, you could get E by that. That's just like having other causal cakes for getting improved student scores. You don't have to have homework. You can have, there are a large number of things that Cooper suggests as alternatives where homework won't work. But one of them is better teaching. It's not that teaching is usually bad, but better teaching can help. Okay, so the thing is that when you've got these two valued variables, E is actually just a sufficient condition. Each of these is a sufficient condition for E to obtain. And none of these factors, this is a necessary part, right, of a sufficient condition, which sufficient condition is unnecessary for the cause. So that's the Inus condition business. And this is the two-valued analog of the formula CP I wrote down, which is one reason why I wanted to write it in that simple form. So in each case, these are sufficient for E to obtain. But now when we have a more when we have a continuously varying variable, or a varying variable, more than 2 valued, things get a little more complicated. And these factors are sufficient, each of them, for getting a contribution for y's, to y's value. And if you didn't have any of them, you wouldn't get any contribution, but as soon as you've got one of them, you get some contribution to y's value. So contribution, okay. Let's turn now to the issue of evidence, which is where we were trying to go. Recall, evidence is a 3-place relation. Okay, is evidence for H relative to a good argument, A for H. So what's the argument that makes RCT results evidence that the policy will work here? So we've got an RCT result in Tamil Nadu. What's the argument that makes that positive result in Tamil Nadu evidence that the integrated nutrition program will work here? What's the argument that makes, it wasn't an RCT result, but what's the argument that makes the case control studies had they been randomized control studies, what would make the argument of the randomized control studies on bicycle helmets relevant to there in Minnesota, relevant to what happens here? Okay. Well, positive RCT results imply, okay, remember, I'm just going to rehearse what I showed you. The policy plays a positive causal role there in the study population. It's right there in the equation. And there was a good distribution of helping factors there. Okay? Good means that we didn't really talk about the fact that sometimes the very policy you have in mind can produce negative results as well as positive ones. And if that's the case, then you don't get a positive average unless the good effects outweigh the bad effects. If it doesn't produce bad effects, it just sometimes doesn't produce any effects, then you'll always get a positive effect size, but it might not be very big if the distribution of the good betas isn't very, if you don't have many of the good betas, you're not going to get very strong positive results. So positive results imply these two facts. Okay, so here's the RCT argument. Okay, Y in study population, which is what we're going to assume, Y in the study population is determined under a causal principle of that right form. If there's a probability measure for the study population, then random assignment of U's to the treatment and control. All right, that gives you that the treatment effect in the study, and the treatment effect in the study population is greater than 0, you can conclude something about the study population. So this is the RCT argument that I sketched. I just wanted to lay out so you can see that I have an argument here. I have an argument that has the positive results as one of the premises, and the conclusion, what conclusion can you draw? This is about the only conclusion you can draw, filling in other true premises. So this fits exactly the argument theory of evidence, but it shows that this is evidence for that. Okay. Now, I want to join that. Remember, what we're trying to do is to get all the way from positive RCT results there to expecting success here. So I've only gotten a little way of the way because I'm still talking about there. So how do we get over to here? I'm going to concatenate the RCT argument with something I call the effectiveness argument. And you can imagine what it is, right? The effectiveness argument starts with the premise the policy plays a positive causal role and the principles determining the effect in the study population. That's what we want to use as evidence. Okay. Well, if the policy can play, which would be can play, the same causal role here as there, and there's a good distribution of helping factors here, then the policy will produce a positive effect size here, a positive treatment effect here. Okay, this is just sort of trivial. That this says that if X appears there in the causal principle there, X will appear in the causal principle here. This says whatever the helping factors for here are, we've got some of them. Therefore, the policy will produce a positive effect here. I'm sorry, I switched from treatment effect to effect size. I'm sorry. Okay. So now you can concatenate these two arguments, and if all the premises in both the arguments are true, then you have a good argument that'll take you from positive results in an RCT to the prediction that the policy will work here, okay, if all the premises are true. Okay. Well, there's a lot of discussion about real RCTs and when the effects of real RCTs are true, and when the RCTs are done well enough to guarantee the premises in the RCT argument. What there's essentially no discussion of is these two premises. And without these two premises, you can't get anywhere. You can't get out of the RCT population unless you've got premises like these. And the question is, where are they coming from? Okay. So this is my picture of how you get from positive results in the RCT to the fact that your policy will contribute here. The result in the RCT is leveraged into evidence for the policy will contribute here, first by the RCT argument and then by the effectiveness argument. So what happens if the premises in either of those arguments fail is the whole thing comes toppling down. I like these toppling down pictures, you realize, right? Because all this heavy stuff, and then suddenly it's just lying on your toes. Right, okay. Okay, so bicycle helmets. Let's go back to applying these lessons to bicycle helmets. What went wrong? Well, missing support factors. Okay. Remember, we had these case control studies in intuition. We might even have had some RCTs. Helmets reduce head injury. Okay. The time series studies, though, show that many jurisdictions that implemented helmet laws don't have noticeable change in the rates of head injuries. And is this a contradiction? No, because what the case control studies were doing, just like an RCT, is they're giving evidence on one ingredient, okay? Not on the whole cake. We studied one ingredient, but we didn't look at the other factors that have to be present. So we didn't look at premise 3 in the effectiveness argument. And what the conventional explanation is that helmet laws, when they were introduced, they didn't just improve the wearing of bicycle helmets, but they disimproved one of the helping factors, which is how careful the motorists are being, and also another of the helping factors, which is how careful the bicyclists are being. So rather than improving bicycle safety by the very implementation and rolling out of the rules widespread, we did change as it were, the salient cause, but we also changed other factors in the cake. So we didn't here have an assurance that the support factors necessary for the policy to work in the new environment are indeed in place. In fact, our very action of making the widespread eliminated support factors that would have been there otherwise. Okay. So, similarly, what went wrong in Bangladesh? Well, what went wrong in Bangladesh, I wouldn't have put so much as a matter of the helping factors or the support factors being missing, but rather that the policy didn't play the same causal role. It just it didn't play the same causal role in Bangladesh as it had in Tamil Nadu. Educating the mothers is simply not in the causal principle in Bangladesh as it was in Tamil Nadu. So let me explain that. The causal principle that we relied on, the very one that had been shown to hold in Tamil Nadu, didn't reach to Bangladesh. Right? It was a true causal principle, and it held in Tamil Nadu, but it simply didn't. That causal principle didn't cover all the way to Bangladesh. And there were two problems. Okay, the first is men and mothers-in-law. Okay, so here The World Bank posthoc evaluation is done by Cartwright, and Cartwright tells us the program in both Tamil Nadu and Bangladesh targeted the mothers of young children. But mothers are frequently not the decision makers and rarely the sole decision makers with respect to the health and nutrition of their children in Bangladesh. Women do not go to market in rural Bangladesh. It is men who do the shopping. Okay? So you educate the mothers about what the children should eat, and the guys do the shopping. Okay? Older brothers or husbands. Okay? And for women in joint households, meaning they live with their mother-in-law, as a sizable minority do, the mother-in-law heads the women's domain. That means the mother-in-law is in charge of who gets what. So you educate the mothers about what the children should be given, and the mothers-in-law decide what the children should be given. Okay? So mothers simply do not play the same causal role with respect to nutrition outcomes in Bangladesh as they did in Tamil Nadu. Okay, so conclusions, which are very straightforward. RCTs may indeed be the gold standard for establishing it works somewhere. It works there in the study population. And we can, if you could do an ideal RCT perfectly, we've got a deductive argument that shows that getting a positive result really does indicate that the policy plays a positive causal role. It actually appears in the causal principle for the study, and that the helping factors are there in enough cases. So RCTs are indeed, I think, a gold standard for establishing it works somewhere if only we could do them perfectly. Okay. Okay. So they can provide you with a solid departure point when you're trying to reason from about whether a policy will work over here. But you can't pave the long road from it works here to it'll work there, and it'll work for us with gold bricks. Okay, so thank you.
Yes. Could you just go back to the slide where you had these what you needed to be able to move from here to there? Where was it?
Yes.
This one, yes. This one, no. This one, yes.
Yes.
So 2 and 3. This is what you need to be able to move from there to here.
Yes.
So my first question is, do you think you can? Because you have those from question mark, question mark, question mark. Is it possible is it possible to move from here to there? And how do you do that?
I don't think you can do so. So one of the lessons is doing more and more RCTs doesn't help. There's some hope. Okay, doing more. You asked a big question, right? Doing more and more RCTs will definitely not teach you anything about the helping factors. I mean, of course, you can do something with the RCTs that you're not actually allowed to do, but which it would be stupid not to do, which is to do some subgroup analysis. So you can look to see whether or not in the Tamil Nadu population, I mean, if you were only, in the bicycle population, right, you could do some subgroup analysis and see that maybe in areas where, or among groups of people where the bicyclists are, like me, extremely risk averse and are going to be careful even if they are wearing a helmet. You might be able to notice that. Seeing it in the RCT is no guarantee at all, because we know very well that you will always find accidental clumpings, and that's data mining. But you can use the you can look at the RCT data as a sort of clue to what the helping factors might be. So we're just talking about the helping factors so far, but it's not so good a clue is understanding how and why the policy works. Okay. And that requires a very different kind of thought and analysis and theorizing.
So are you saying that we put too much faith into those kind of RCTs? We should do other kinds of...
We should definitely do other kinds of investigative research, because you really do. You can't make a prediction about what's going to happen here if you don't know what it is that enables the causal factor to work. So so you need to do that, and it's not something that will ever come to you from an RCT. It requires whatever it takes to understand what's relevant. So one of the examples is I use sometimes is you have a load of rubbish in your driveway and you want to move the rubbish, and there are good RCTs that tell you if you hire an industrial magnet, you're more likely, it moves the rubbish more often than not. But what you need to know whether it's worth your hiring the magnet is whether or not what you're trying to move out of your driveway is a bunch of cardboard boxes or an old car, because the industrial magnet needs as a helping factor that it's ferrous material that it's moving. How do you do that? You don't do that without theorizing. And now what does it mean to theorize? And what's the whole network of activities that help you? That's a whole question for scientific methodology and philosophy of science, but it certainly isn't something done by doing RCTs. It is the case that if you've got a very good hypothesis about something that's a helping factor here, then it's just a cause. All those pieces in the cake are, they're all causes, they're all Inus conditions, so you can actually do an RCT on it. Once you've got a candidate beta, okay, for this population, you can do an RCT on it in this population. It doesn't tell you whether those will be the helping factors over there, of course. But that was only half an answer, but I've been talking so long.
But can I just ask just a small question? And I think this is perhaps not even possible to answer, I don't know. But I was thinking, suppose that you have a good understanding of the whole cake in a situation where you've done this kind of RCT over there. And then what you're saying more or less is that one factor at least is that it's not just the cause it's not just the cause that matters, it's the whole cake that matters here for us to know if we will get the same result. So, and what I was just wondering, what exactly does that mean? So does that mean that you're saying that in order to learn something from an RCT coupled with information about the whole cake over there, we need to know that we have the same helping factors? And what does that mean? Do they have to be identical helping factors, or is it enough that you can kind of in some way find out if their contribution amounts to the same kind of degree, or they help as much? Perhaps they're not the same, but they help to the same degree as the helping factors over there. What do you think is needed?
Well, I think, regret that I think all this is really hard. And that's the human condition. It doesn't mean you shouldn't try to do policy and you shouldn't bet and so forth, but the first thing to note is what you said, that the very same policy could be effective in two places, but with different helping factors. So in the Bangladesh case, supplemental feeding was a helping factor. Teaching whoever's in charge isn't going to help about what to feed the children if they don't have any food to feed the children. Supplemental feeding was a helping factor that was necessary and sufficient in Tamil Nadu. Supplemental feeding turned out not to be the requisite helping factor in Bangladesh. It wasn't the helping factor for a very strange reason, is that the right helping factor, there was a shared helping factor. I'm sorry, here's not a good case because it's a case where there really is a shared helping factor. It would be the same if only you identified it properly. So over here, the supplemental feeding, the food that was offered, called supplemental feeding, was actually given to the kids. Over here, the supplemental feeding, exactly the same thing, that was, they thought it was the same helping factor that was given to the kids. That's not the helping factor that really, that's not the name of the helping factor really. The helping factor is getting the food into the kids. Over here, there's food leakage. The food either went to another member of the family or it went to that kid instead of it's another meal it would have had. So, I'm sorry, there is a case where there's helping factors at one level of description were the same. Right? So at least they were the same. We just didn't recognize what that level of description is. But there are lots of cases where the helping factors simply aren't the same at all. And how do you know that? Sorry, you have to really, I think, understand how the cause operates, and then you could see what kind of thing is necessary. And it's not till you understand something about magnetism that you know that sometimes the magnet works, sometimes it doesn't. Well, you've got to know what the helping factors are. Again, there's a case where the helping factors are universal. But how you get, when they're not universal, you really do have to understand how it works and why it would work in the local situation. And there's nothing for it but the hard work of trying to figure it out. I mean, the RCTs are like it's called sometimes in literature, silver bullet. Gold standard and a silver bullet. I like this. I'm not sure whether being gold is better than silver or not, but at any rate, it's a silver bullet. And there just aren't any silver bullets. There's no kind of shortcut to hard, complicated, no manual for it, scientific work. I mean, there's a manual for RCTs, but there's no manual for how you do the hard theorizing and detailed investigation. I mean, what do you have to do to find this out? I don't know. You have to do real science. Sorry, that's trying to sort of explain how I see it. Ingvar, are you going to ask the same question again?
No. I agree with more or less. I think, as I've understood, I agree, so it's no criticism. The question I'm going to put forward, I think I even can guess your answer, but it would be nice to hear what you yourself are saying. And if some medical people have not fooled me, they have said like this, that, the RCTs are no longer regarded as the golden standard. Now it's so-called meta-analysis done by the groups called Cartwright groups. And for those of you who don't know it, it's merely that some people sit down, take a lot of RCTs done with respect exactly, more or less exactly the same kind of disease or the same kind of treatment and so on. And then they look upon that. Sometimes they come to a result that cannot be found in any of the specific RCTs. So I would simply like you to say some words how you expand this position of yours to apply to meta-analysis as well.
Yes. So it's not just the Campbell collaboration, the Cochrane collaboration. For social policy, the analog of the Cochrane collaboration is the Campbell collaboration. And moreover, there's 50 at least, or 100. I mean, if you just look worldwide, must be hundreds of different agencies that now demand impact evaluations, and because they demand them, then they have to write down some rules for what you won't get the money unless you're going to do an impact evaluation. So they have to write down what a good impact evaluation is, right? And that's an RCT. But then very often these, if you want to have really good knowledge that the thing has worked somewhere, and then you want to have a meta-analysis of a number of RCTs. What a meta-analysis does for you is it gives you a larger study population. Some of the pharmaceuticals pills can sometimes relatively easily be tested on large populations. A lot of medical interventions cannot be. So there are small new hips or new bits of surgery that have to be done in hospitals where, etc. So, and certainly the social policies are usually done on small samples. So and the small samples, you could just be seeing, independent of any flaws in the setup of the RCT, which flaws are very difficult to eliminate because of the difficulties of just doing real science. But even if everything were done perfectly, you could still be seeing a statistical anomaly. You flip a coin 10 times and you could get 10 heads in a row. And so that's all. What's a meta-analysis is, it kind of makes an artificial large population out of all these small populations. It throws them all together. There's a problem because none of them really have the same treatment exactly the same treatments, and they didn't measure exactly the same effects. So you do a lot of statistical, they have different dropout rates. I mean, there's an enormous amount of statistical correction that goes on in doing a meta-analysis. So the first thing to note about meta-analyses is that the manual isn't objective. And so a lot of people who've compared meta-analyses on the same studies done by different individuals or different groups, it turns out that different statisticians take exactly the same set of studies and their meta-analyses come out with very different results. So that's the first thing, is that you don't have this kind of promised level of objectivity. That there's no judgment involved. It turns out to be very sensitive to judgment. But moreover, I mean, what you see is what you get's exactly what you put in. So what you find out is you don't know that, this is a long story, right? You don't know that each of these populations is governed by a single causal principle. So you might be getting a mix of causal principles. So what you'd be getting is an average over the effect sizes in each of them. And if you get positive results in the meta-analysis, it means that at least one of those causal principles, the policy played a positive role in. And in some sense, you have a bigger population, but in another you don't, because unless they really are all governed by the same population, you don't really have the appropriate kind of population. I mean, with same causal principle and same probability measure, you don't actually have the right. Your study population, which is supposed to be just all clumped together, the statistical methods only work if they actually have the same probability measures, and there's no guarantee of that at all. I mean, the probability measures are, I think, as likely to be diverse as are the causal principles. But okay. But there may be an expert on meta-analysis in the room.
You mentioned the level of description as essential here, and to take very small examples, you mentioned head injuries without specifying yes. whether it was the frequency or severity. A more typical example might be if you give kids math problems to solve at home and you get a successful result in a controlled trial, you are likely to report that as the success of giving homework. Then someone else interprets this as asking the kids to memorize historical data or something like yes. that. So you go unnecessarily abstract in your description. And this is maybe not a philosophical, but a social problem, really, that people tend to report it. And I have a specific case in mind, namely the idea of quality in education, which to my mind is such an unnecessary abstract description of a lot of things, and which has great impact on actual social policies. So my general remark here is perhaps not much of a question, but rather the asking for your comments on how do we describe things on an adequately abstract level in order to still make it possible to transfer from one application to another, but not giving a wild ticket to go everywhere.
That's my answers. All these questions essentially are the same. It takes real science. So there's always there. Just to expand on Banks' remark, there are two pulls. One pull says, look, if you've done an RCT and you want to institute the policy elsewhere, you'd better be absolutely faithful to the details of the treatment as it was described in the RCT protocol. So the point about an RCT is that it is manualized, and one of the points is you're supposed to describe in operationalizable detail what the treatment is so that you're sure everybody really got the treatment. You know what the treatment is and everybody got it. So you've got fairly concrete descriptions of the treatment and very concrete descriptions of the outcome. Again, that's part of doing a rigorous RCT, that you stick to the protocol, that you've got operationalizable, clear, concrete protocol. So one claim is that what's been tested is, as you said, the effect of doing these kinds of math problems at home, and it raised these kinds of scores on this kind of a test. Right? And if you want to export it, you better be, fidelity is the word, you'd better do exactly the same thing and only expect results about exactly the outcome that was in the protocol, because that's what's been tested. Right? We didn't test homework, right? We tested this specific kind of homework. So that's one argument, and there's a push then to fidelity. Then the other side of it, though, is that usually things that are very, very, very concretely described are not the level at which at which you find general truths. So that normally, in order to get something which is going to hold somewhere else in an interesting way, you have to have a more abstract description of it. So I think that the example of the supplemental feeding, right, the very concrete description, which was in the protocol, give them so many calories, which mixes protein and so forth in the right way, and give it to them Mondays, Wednesdays, and Fridays. Hand it to the mothers Monday, Wednesdays, and Fridays. That wasn't the description. There actually was a description that was, could travel. That if you did it here and there, you did that same thing here and there, which is make sure the children ingest those calories and that amount of protein, etc. Right? Which I think is a more abstract description, because over here, right, just giving the mothers the food to take home constituted doing that, and over here it didn't. And so you need first to know exactly what's the level at which which you can find something general enough to cover the two cases, and then you have to know what constitutes the concrete operationalization of the more abstract concept over here. And how do you do that? That's the work of real science. That's the sort of standard example I use is if you're doing this is stupid. It's a very diagrammatic example. But if you're doing experiments on motion subject to no forces, so you want to know how bodies subject to no forces travel, and you're doing them here, experiments, you can do any number of experiments and you'll always get the same result, is that they travel like this. Right? They travel on a Euclidean straight line. Now, if you move to a spherical geometry, that simply does not travel. Right? That result is local. It's local to Euclidean geometries. If you're on a circle, on a sphere, then bodies subject to no forces travel on great circles. And if you're on a saddle, right, they'll travel like this or like that. And there is something that you can learn on the Euclidean plane that's true everywhere, that bodies subject to no forces travel on geodesics, on the shortest distance between 2 points. But you don't, how do you learn that? Again, that's what real science, that's what we do in real science, and there's no scientific method for how to do it. But you have both to learn that it's geodesic, which is just the right description, and then what counts as a geodesic on your new funny geometry. Is that Go ahead, Bengt.
Thank you very, very much. I'm very happy that you made the distinction between RCTs and real science, because I'm so worried about RCTs being considered gold standards. They're not that, because they are by definition only looking at the superficial result, superficial in relation to the observational level you have. And they, by definition, disregard working mechanisms, which are put there in place by real science. So in order to get somewhere, you need the two, and you need the two in a way that they really connect.
Yes.
Thank you.
And can I just make I mean, I suppose I'll talk about, maybe I won't talk about this, but working mechanisms, you can, has a lot of different meanings, and sometimes when medical people talk about the mechanism, they mean what I would mean by the causal pathway. And so, you know, how does it happen? Well, it does this first, then this, then that, then that, then that, then that. And of course, you won't get the outcome unless the helping factors are there at each stage. So understanding the mechanism in the sense of the causal pathway is really important. But there's another sense of mechanism, which is the kind of Bechtel, MDC, Cartwright sense of being some kind of underlying causal underlying structure that enables this causal pathway to happen, that Bangladesh and Tamil Nadu have very different socio-cultural economic underlying structures, and that's why the causal pathway from educating the mothers to child nutrition is enabled to happen over here, but it fails over here. So I think you need to understand that mechanism in both senses, and that otherwise you're just not doing proper science yet. I mean, we're getting on with it, but
yeah. Thanks for an interesting lecture. As someone who works within drug development and with clinical trials on a daily basis, I think it's very reassuring to hear that your lecture and your doubts, the doubts you're raising about the current prevailing methodology of randomized clinical trials as being the golden standard. Because I think there's also in the academia, there's a big concern within the industry, pharma industry, that the RCT methodology no longer works. It's sort of outlived itself because there are so many kind of flaws in the ways it is being used, and most of all, I mean, one thing is the lack of generalizability of the groups, and another one being the extreme placebo effects that are seen, particularly in studies that are done in the US for many reasons, possibly for patients being paid quite a lot of money to participate, and possibly for the kind of patients that are used in those trials. What do you think would be the perspective? It's quite interesting to hear from a philosopher's point of view, you as a philosopher. What do you think will be in the future? I mean, you're hinting at subgroup analyses, you're hinting at data mining to try and really get behind the standard kind of clinical trial outcomes that we have. Do you think there will be some kind of, I mean, I've read sometimes now in journals speculating that the current development within data management and advanced software, that there will be ways to, in huge populations, to try and identify potential effects in a more naturalistic, with a more naturalistic background, so to speak. Yeah, well, what do you think is the future? And the regulatory authorities, I mean, they're so stiff on the RCTs, so it's quite difficult to change.
I think those folks are off and running doing that. I think that I wouldn't want to put very many of my eggs in that basket, because I really do think, following Benk's suggestion, that you make headway by, but this is probably because I have this background in physics, where we know things and we know, well, I do think that you're going to make headway by by re-allowing information about mechanisms. So, you know, one of the things that, not for you, but when you export that, so he's describing problems in the medical settings themselves, but when you export the medical hierarchy, for, you know, with RCTs at the top, etc., to social policy, you've dropped off a whole lot of what's happened already in the medical test, because it's so expensive to test anything. that you don't bring a new product to a last stage RCT unless you've already done all this other stuff and have a lot of high prior personal probability that it does work. And in the Campbell collaboration, when you're doing social policy, there's no indication that the RCTs are to be put on top of all this antecedent information. But now, when we've got the RCTs on top of it and they're still not good enough, then I think you've got to loop back. One of the things you have to do, you shouldn't stop looking at large datas and data mining, but you should loop back and really start reinvestigating exactly what the causal pathways are and what the theory behind the causal pathways is. And you're not allowed to use theoretical derivation as evidence in any way, and that's mad, I think. And the reason, and I take it, one reason is we're in this period of not trusting, and theory seems to be much more manipulable in the hands of the theoretician than the statistics are in the hands of the statistician. But I think that's just a problem, a scientific political problem you have to solve.
And I guess a problem for the authorities, regulatory authorities also.
That's what I meant. They have to solve it. I mean, that they're not encouraging us to look just where we need to look because everyone feels it's that if you allow that kind of putative information, it's too easily manipulated. So you've got a kind of problem of honesty versus effectiveness of your evidence. So I think you should look over here. You should do much more theorizing. The well-established theoretical claims should play a much better role. But there's the problem that they're much more easily manipulated for profit and self-interest. And so there's a practical reason not actually to do the very scientific enterprise that can help us.
It's a lot of money wasted. I mean, it's $1 billion and
yes.
In each development of each drug. And frequently they fall on the last, just before the finish line.
And then there's all the problems about you only monitor for side effects over the short term. You don't know how to, they're not very good. RCTs are not a device for monitoring for side effects. The regulatory agencies have to make you do it in some other way, and the side effect thing is not done in a way where you can show that what you're doing to look for side effects is actually likely to turn them up, etc.
It's a question, of course, what to believe and not to believe, and what to trust and not to trust. And you put up a title here, randomized controlled studies. But the interesting thing is that people have different inclusion-exclusion criteria when they're going to go through studies. And I just review a paper. They had 2,663 papers they were looking into. And at the end, it was an American study, came out with 3 papers, and 2 of them came from the same author. And from that they were based. And the problem here is that, they put up, conventionally you have to fulfill a number of criteria. One is, for instance, you have to mention when the study was performed, from the 1st of January to the 31st of August or something. If
sorry, I missed the last few sentences.
You have to state exactly when the study was performed, and if you have forgot that, the study is out of the comparison. So this has become a problem, and we had another study with people in the UK, and then they were evaluated 263 papers, and they come up that there was only 6 that were supposed to be valuable to include. But then we count another problem is that if you don't know who is doing the study and personally don't know the person, you may question, because in that case 2 of the 6 studies that of the 263 fulfill the criteria came from Plovdiv. And you know, of course, what Plovdiv is? No? We spoke to somebody in Harvard, and the woman that was from Plovdiv. So we said, we have some collaboration with Plovdiv. No comment, nothing. Everybody knows where Plovdiv is, so that's a joke now we have. But that in that particular case, this clinic visit was they were investigated person without electric lamp. So whatever they said was nonsense. So that is another thing. How should we track down and identify the quality of the person who produced studies and data? That's a problem.
It's a problem, and it's one that usually I take it when you were talking about studies that it sounds to me like what I would call a systematic review. So when you look at these evidence hierarchies, what kinds of things are good, we not only have at the top meta-analyses of RCTs, but systematic reviews. And then a systematic review by something like the Cochrane or the Campbell collaboration has rules for what kinds of studies it will count as good studies that they're going to review in order to tell you. So a systematic review is supposed to review all the good evidence and see how it weighs up, or hope it all points in the same direction if it doesn't explain what's going on. But as remarked, the criteria for a good study are so strict, and in particular, they really do require randomization, that by the time the review's been done of the studies, you start out with hundreds of them and end up with 5 or 6 to review, which has a number of lessons. One is the lesson that a lot of studies are flawed, which we know. Science is really hard. Sometimes people are being dishonest or concealing things, but sometimes it's just that studies are hard. But the other thing is that the criteria then are telling you not to look at the other 270 studies because they weren't good enough. Only these 3 meet the high standards, and that seems mad to me. I mean, that's just not doing the hard job of looking at all the evidence and figuring out what should follow from it, which is a hard job, but of course, again, you can't do it mechanically. And then we have the issue of trust. Then the other issue is, and I've been in trouble with this at a Nordic Campbell collaboration meeting years ago. I didn't get invited anymore. The fellow who was really defending these systematic reviews said, here's what used to happen. You ask somebody to write a review of the literature. Where do we stand with respect to drug abuse among 13-year-old inner-city British kids? And you ask somebody to review, to write a review of where we stand, what does the literature show, and it's always a guy, right? It's a guy who'd go, and what he does is he's go to his file drawer and he gets out his papers of his friends that are in the file drawer, and writes a review of what's in those papers. We now have rules for how to decide what studies should be in the systematic review. And then, I noted that exactly the thing you mentioned, that many of my friends in physics, in particular a couple of really, really good experimenters I know, that's just what they do and just what they think they should do. They go to they're good experimenters. They know who the good experimenters are, and when a good experimenter gets a result, they believe it. So I have a friend who spent 25 years putting gyroscopes in space to test a specific implication of the general theory of relativity. And 3 years before the outcome, somebody else did not exactly as similar, but testing the same kind of consequence of GTR. And Francis said, okay, it's settled. I mean, we all thought it was settled anyway because he believed the GTR result. But why? Well, that guy's a really good experimenter, right? And so, anyway, the physicists, many of the physicists I know, trust to some experimenters and not others. How do they know? I don't know, just the way you know when you hire somebody or admit a graduate student, but it's not something that you can manualize. And so then you're back to the issue of trust and who's in control, who's friends are getting the right to make these decisions. I think we have the same conversation that I had with. Oh, he's gone already. Anyway, at dinner last night about hiring somebody you know, right, versus an open and free competition, right, which going through the manual in the open and free competition, because you've got only a handful of evidence, has the drawbacks of accuracy, but fairness and here if you're really good and you know the right people, unfortunately, it probably means that you know the guys who are doing it well. So it's one of those, again, political scientific trade-offs, I think.
That in my opinion, it's really scrutinized and criticized by the Cochrane, mostly because of it's really like mixing a strawberry pie with an apple pie to get this. So yeah, but I have two other comments. Actually, the helping factors, these are also a result. Just as important. Also, it's also a result, just as important as the primary results.
Yes.
So identifying the helping factors is also a result. And I also have a second comment that if you look at in life science, that they're moving more outside UK, US, and Europe for these RCTs. And in your discussion, maybe you don't need to answer this, but what will it be in the future for the RCTs if it's moving to other countries? Is it also from here to there?
Absolutely, it's from here to there, and there's a kind of assumption that people are people wherever they are, and so you can test drugs for Upper East Side New Yorkers on people in Indian villages, and I think that's. I want to see the evidence that people are people with respect to this drug, this outcome, right? This population. And the other, of course, is that you're getting. There's always the. We never do RCTs on a sample of the target population, partly because, in principle, that's not possible since time passes and the target population. But even as it is, and when you're and when you're exporting the drug trials, there's all the problems that people raise all the time. That the study populations won't have some of the other relevant other diseases that affect how this treatment affects this disease. They won't have some of the other drugs that people are taking. There's a catalog of problems with taking your trials elsewhere, apart from the ethical ones.
So the future doesn't look so good for the RCTs.
Well, it doesn't look good to me. I mean, the ethics committees, I hope, are getting certainly at LSE when you want to do social tests. It gets very complicated about the ethics committees for doing a trial there, whether or not it's meant to find out about there or it's meant to find out about here.
Thank you for some very interesting lectures, and I would just like, I'm an economist, I would like to make some comments from the social science point of view, which is rather different from the medical trials, etc. Because we have, always had problems because it's very rare that we can make real random controlled experiments. But at present there is an extreme hype in economics that you should be doing things that are similar to that. And I think we have three different areas where one is that you actually make controlled experiments. For example, you look at differences in risk behavior, often with student population, etc. So that is fairly close to random controlled experiments, but still has the problem, could you could you extend this and apply it to other kinds of populations and student populations, etc. But perhaps more interesting, you have this area where you're doing experiments, and where, for example, Esther Duflo is one of the main figures who've actually pushed a lot to do control experiments in the development, economic development situations. And she is trying to do things with, development projects, etc. And I think it's very good in the sense that you can learn about what's happening. But at the same time, I think she is actually doing the things that you are talking about, because she is not only looking at the coefficient, the betas, etc., but she is also trying to find out the embeddedness or the cake, other factors. What kind of areas are these experiments taking place in? And for example, if you look at her book, recent book, Poor Economics, she's also making a lot of interviews. And also, as interesting as the positive results when you get the effects you wanted, are the results you get when you don't get the effect that you wanted, because that makes you go into the underlying social culture, the culture of the poor, and find out why did it not work the way we expected it to work. For example, your Bangladesh case is. So I think it's very good that you're doing this, but at the same time you have to use these other kind of methodological approaches to understand what's going on and the character of where they are taking place. Another area which is presently also in economics...
But before you go on, because I'll forget, because I've already got 2 comments. Okay, but wait, hold your third. First, I tend to be popular with suddenly with some of my economist colleagues, because I actually think that I can prove that certain with the right kind of background knowledge you can get equally good causal conclusions out of econometric by econometric analysis, and that's econometric analysis on population data, not on study data. And it just really depends on how much background knowledge you have. But in some cases we have background knowledge, and demanding that you do only RCTs. The Campbell collaboration, if you look down the list, standard econometric methods are nowhere on the list. It's not that they go down through really, in a sense, very, very bad attempts to do statistical comparisons between one group and another, where you've got no control at all over what the confounding factors are in the 2 groups. And they don't even have econometric analysis in it. And most of the medical people I know never heard of it. So one thing is, I think that there are powerful tools in economics, is only if you're allowed to use background factors. That's the first thing. Second thing is, I don't actually believe you about Duflo. On the one hand, yes, she's a serious person who's really there and gets in. All the Jamil Poverty Action Lab people are on site and really care. As my friend Angus Deaton, whom I work with on this, says, these are the good guys, right? But the story about we have to do RCTs, and then if you look at the RCTs, most of them are really, really flawed for internal validity. The demand that you do them, given they're very flawed for internal validity, and you need all this other work, and the other work has got no manualizable rigor to it, that's, I just can't buy that you should be pressing. Of course, other things being equal, it's always nicer to have another study in RCT, but the suggestion here is we should, well, actually, she does say, right, the World Bank should only fund things that have been RCT'd, and that seems to me a mistake.
Yeah, that's actually on the agenda in Sweden today, because the Ministry of Development is going out saying that all Swedish development aid should actually be result-based. So if you interpret her in the terms of what we've been discussing here, she's actually demanding that all Swedish development aid should be based on RCTs, which I think it's not going to work, and it would demand enormous things. So I don't think that is. So I think that's been an oversell, definitely, in this area. The other thing about economics is that, to in terms of the old econometric techniques, what everybody's looking for now is trying to find situations where we have so-called natural experiments. And there again, I'm fairly skeptical, and it's sort of, to me, is the character of, you know, where you've mislaid your keys and you're looking under the street lamp. So it's only under the street lamp. So there's only in certain areas, certain time periods, when you change the Swedish school system in the early 1950s, etc., where you can find these street lamps and natural experiments. So again, I think there's been a misplaced emphasis on only being sort of allowed or being published if you're doing these natural experiments, and sort of scoping out the old econometric techniques, which I think still has a room because they can, you know, they can cover more time periods, they can cover whole populations, etc.
Yes. So I also worry about that because not only is there the problem that you then investigate just the cases where you can find the right characteristics of the instrumental variable or the right characteristics for a natural experiment, but then you have the problem that we started with, which is that's always on the non-target population. It's on, as you said, something happened in Swedish schools in 1950, and surely things have changed. The tyranny of method here is, I think, really having a bad effect. On the other hand, you know, I do want to, you know, keep stressing, I really do believe in this story about the argument theory of evidence, and that if you're using more conventional econometric methods, then, and you really want to draw causal conclusions, there are going to be some pretty strong premises about other causal factors at work, whether you've included them all in your study, whether there are certain independence in the error terms. Anyway, there are different ways to get causal conclusions out of an econometric model, but they all require strong input. And now that's not a reason at all to throw them away. It's a reason to do them and to make clear what the other premises are so that you can hedge your bets. But that's exactly what's happening with these RCTs. They're done as well as people can do, and they're hugely flawed. So when you're trusting that you've found out a causal conclusion from them, you're also you're betting, and you should hedge your bets. But it seems to me that it's very odd to only find out the results, the kind of results that could be found out by a particular kind of method because you like that method, when there's a lot you can find out by other methods. Okay.
So I have a question about the causal concept that you assume.
Johannes, I'm sorry.
Yeah, no.
I have to move. I can't. You're exactly where I'm looking at the light.
Oh. So the causal concept that you assume for instance, in the effectiveness argument, and it leads to problems that's quite obvious when you look at premise 2 and 3 with external validity. So I guess the Einer's condition concept of causation is very good in combination with RCT, because you can prove causation, you can get internally valid causal conclusions fairly easy with that kind of causal concept.
Yes.
But then on the other hand, that's not the only causal concept available. You could have selected another causal concept, which perhaps would have made it much more difficult to prove causation by using RCT, but on the other hand might have simplified the picture when it came to questions of external validity, for instance. For instance, if you had adopted a union causal concept.
A union causal concept?
From David Hume,
oh.
Where causes are sufficient for their effects. There is a law. Of course, you cannot prove that kind of causation by doing a randomized controlled trial, but if you find it, then you will have no problem going from one country to the other, for instance, because
yes, absolutely. And that you don't have to have a causal concept. If you've got an absolute regularity that holds everywhere and every when, it doesn't matter whether it's causal or not.
No, but it could, my point is, that could have been what we meant by causation, and it was once upon a time. But now, for some reason, we have another causal concept, more in line with
we have a causal concept that's both weaker and stronger, because it's you don't assume that it has to be a uniform regularity. You could have probabilistic theory of causality that I'll talk about next time. And also, in my view, right, you can have very local causal principles, and I think I understand in many cases why those local causal principles hold. I know why I call them causal. I'll talk about that tomorrow. But I have another causal concept, which is the concept of a causal capacity. And a causal capacity is something, if you know about it, right? A mass, I'm going to use this example tomorrow, but a mass, it attracts other masses no matter what else is going on. Right? But you can't find out about that, as you say, in an RCT. Right? But then how do you find out about it? Well, you do some RCT, you do something that's the equivalent of some experiments, but how do you find out that it makes this contribution everywhere? Well, that was hard science. But it is a different, I agree with you. My view is that it's a different causal concept, and it's really important to make clear that it's a different causal concept because it has both different, it requires different methods to be entitled to attribute a capacity or a Humean regularity than the ones that we typically do in the social and biomedical sciences. And also, you can draw different conclusions from them, and in particular, both the Humean absolute regularity and the causal capacities, you can draw conclusions much more widely. So I agree. There are a lot of different causal concepts. That's just what I'm going to talk about tomorrow.
Okay,
I mean, exactly that. I'm going to say, look, there's causal laws and there's capacities, and I'm not going to talk about Hume, but we can...
Okay, then we end it.
Okay, thanks. Yeah, it was very interesting, this question that you brought up about whether we should mechanically follow a manual or whether we should trust trustworthy people, both in science and in other areas of life. So, well, it seems to me there have been many attempts to mechanize science. So the inductivism, that seems to be one such an attempt to create an inductive logic. And the randomized controlled trials, that's another attempt to mechanize science. So many of these attempts, they have failed, obviously. But still seems to me that hasn't this drive towards mechanization of science also done much good? That, I mean, you can go too far in the other direction also to just assume that, well, the trustworthy people, they are really trustworthy. But well, yeah, the
trustworthy people have gotten their knowledge that they're trustworthy about from somewhere. Yeah, so...
So, yeah, so what's your general picture of this? I mean, my take would be that, well, this notion that we need some rules in science, there's some truth to that, even though, well, we can't have that rigorous rules as some people might have thought, but yeah.
Well, I think you can imagine, I waffle. I think that you need, that if you have rules, they have to be very abstract. Otherwise, they simply bind you to do things which don't make sense in special cases. You see that in bureaucracies all the time. But if they're very abstract, then you're back to there not being a rule about what constitutes the concretization of the rule in this case. So it's just like geodesics. Right. You don't. Rules have to be expressed in the language of geodesics, not in the language of Euclidean geometry, or else the rules will just give you bad results in new cases. But you have to figure out what's the right level, and then you're still left to. The nice thing in physics, very putatively, it's not true, but the nice thing that's supposed to be the case in physics, that is in the old language of Hempel, is that the theories have internal principles, like F equals ma, and then they have bridge principles. And F is a very abstract term, force. But it tells you exactly, given a situation, what force function you can write down. So there are rules, putatively, rules in physics that tell you when you're at this level of abstraction how to get back down to the concrete case. I can write GMM over R squared if I've got two masses. I can write Q1, Q2 over R squared if I've got two charges, etc. I say geodesic, and I know sphere, great circle, geodesic, Euclidean plane, Euclidean straight line, etc. In those cases, it's not a problem that you write the rules in an abstract vocabulary, because you've got rules for how to climb down the ladder of abstraction. For most cases, as in doing scientific method or legal cases or regulation, you don't have those. So you inevitably are going to have either get inaccurate results or rely on judgment at some point. And that's just, again, the human condition, I think. But I think it's a problem, as I understand it, this is a problem with regulation and laws in general, right? That they need to be interpreted. Yes.
So my background is in biology, not in philosophy. But so what I'm wondering is, because in many clinical trials in medicine and how people interpret them, they often interpret them that the effect is the effect in the treatment group minus the placebo group. And as a biologist, to me that doesn't really make sense, because I'm thinking that the placebo enables the effect of the drug, or that they are in fact interacting. So in what sense do you think it is correct then to say that the effect of a drug is the effect of in the treatment group versus or minus the placebo group?
I agree with you that if there's a placebo effect, it's very likely that you're getting the treatment group. I mean, that's the point. The treatment group isn't getting just the treatment; it's getting whatever we mean by the placebo effect. It's getting the two of them. This one's only getting the one of them. If there's a difference between the two, you think it's got to be due to just the treatment. Of course, it's interacting with the placebo effect, but that's the reason you want to subtract off the effect size from the placebo group.
So these enabling factors that you're talking about, are they additive or are they not additive?
In the RCT, the W's, I don't have I'm not allowed to use the board. In the RCT, right, when you calculate the treatment effect or the effect size, the W's cancel out, because you're getting the average of W in the treatment group, the average of W given X, and the average of W given X prime. Randomization is supposed to make W and X independent of each other, so you've got the average of W on both sides, and they subtract out. So the confounding factors that are relevant to the measure of the effect size are the ones you said, the interactive ones, the betas, which are formally interactors.